We'd like to thank the Focus Ultrasound Foundation for inviting us to speak today. We're going to be speaking about sonodynamic therapy to treat glioblastoma tumors. This work was done by investigators in the Department of Neurosurgery at the University of Virginia, as well as the Focus Ultrasound Foundation. Glioblastoma tumors are the most common primary and malignant brain tumors in adults. It's a tumor that causes nearly 17,000 deaths each year in the U.S. alone. The average age of presentation is 64 years, and the reoccurrence rates are nearly 100%. Some symptoms include headaches, nausea, vomiting, memory loss, and speech impairment. Sonodynamic therapy is an approach that couples high-intensity focused ultrasound with a sensitizer. In this case, we used 5-ALA, which is already approved by the FDA and is used to help guide the resection of glioblastomas. 5-ALA also generates reactive oxygen species, which leads to apoptosis as shown in the picture. With the focus ultrasound probe that we used in the lab, we were able to load cells with 5-ALA for approximately 4 hours in advance of the experiments. Then we delivered ultrasound of 1.1 megahertz frequency with a 3-minute duration, 10% duty cycle, and a power of approximately 10 watts per centimeter squared. We did the experiments in the dark to avoid bleaching of the 5-ALA. This is the experimental setup on the right with the cells in a 96 well plate. We studied U87 and C6 glioblastoma cells and tested control, 5-ALA, focused ultrasound, and then the combination of the two. Our results are shown in the next few slides. First, we looked at cell morphology. 5-ALA alone did not cause any morphological changes in the cells. Focused ultrasound caused some slight disruption in the cellular processes and reductions in the cellular body volume. However, sonodynamic therapy decreased appreciably the cellular extensions, condensed cell bodies, and decreased the cytoplasm to nucleus ratio. Then we studied cell proliferation in these various treatment groups. Sonodynamic therapy consistently had a statistically significant reduction in cell proliferation and cell viability as compared to focused ultrasound, 5-ALA, and control groups for C6 and U87 cells. Next, we looked at the caspase-3 activity and we ran a caspase-3 assay. Sonodynamic therapy caused an increase in caspase-3 activity far more than focused ultrasound or 5-ALA, although the two did induce somewhat of an upregulation of caspase-3 activity. We then studied with cytospin and immunohistochemical methods for caspase-3 activity in C6 cells. C6 cells at baseline showed very little caspase-3 in the staining. The 5-ALA created very little increase in caspase-3 staining. Focused ultrasound induced a mild increase, and sonodynamic therapy had an appreciable increase as shown by the darkened cells. We also did staining for PARP1, which had similar results and images to caspase-3. We then did a semi-quantitative analysis of the caspase-3 positive cells. Sonodynamic therapy caused nearly a 40% expression of caspase-3 on immunohistochemical staining, as compared to only a 10% expression for focused ultrasound and about a 5% for 5-ALA and less than 5% for control. This was true for U87 as well as C6 cells. Next, we studied PARP1, which is a downstream apoptosis indicator. PARP1 was upregulated with sonodynamic therapy and statistically increased as compared to focused ultrasound and 5-ALA, which caused modest upregulation of PARP1 expression. Control cells for both C6 and U87 had very little PARP1 expression. PARP1 and caspase-3 are measures of the downstream cascade of apoptosis and eventual cell death. So in conclusion, what we studied was sonodynamic therapy that suggested that brain tumor cells such as U87 and C6, representative of glioblastomas, could be effectively reduced with sonodynamic therapy over and above focused ultrasound and 5-ALA's effects. This approach may be generally applicable to gliomas, not just high-grade gliomas and glioblastomas. We looked at the option of doing this as an adjunct for minimally invasive targeted approaches for brain tumors and it may have some applicability outside of glioma cells as well. Thank you for your interest in our work, and we look forward to further discussion at the meeting.